from August to October are available on our Maine CDC website. So with that, I'll turn it back over to Lisa Letourneau.
Great. Thank you so much, Liana. And thanks everyone again for joining us. Lisa Letourneau, I'm a senior advisor here at Maine DHHS. I'm just really pleased to have you all joining. We have, as Liana said, had several in this series. We plan one more next month in November, and then ideally quarterly after that, but really appreciate everybody's commitment to learning more about issues related to health equity and disparities as we've experienced them, not only in COVID, but certainly for centuries in this country and other aspects of healthcare as well. We know that starting this work really starts with ourselves. And so we're very pleased today to have Judy Ann Smith, the Executive Director of the Daniel Hanley Center for Health Leadership, helping us to bring Janet LaFlamme, who is the Director for Leadership Development at the Hanley Center, to really start with ourselves and look internally at our own biases and implicit bias in how we approach people in settings of healthcare and otherwise. So with that, I will turn it over to Janet just briefly. She's the Director of Leadership Development at Hanley and provides operational leadership and oversight of the various leadership development programs there. She has a long history of service within the healthcare industry and leadership development, as well as human resources development. There's lots more I could say, but I'm going to give the time to Janet to spend the time with you all. So with that, Janet.
Thank you, Lisa. Boy, it's so nice to be up and early to talk about this important topic. Let me go ahead and share my screen now and get started.
And maybe we could just say, so folks know, Janet, that you will be asking people for comments and discussion as we go. And they can also use the chat to put in questions as we go. Is that fair to say?
That is. What we're going to be doing is Judy Ann is going to help me monitor the chat as I go through. There are a couple of times where I specifically ask for feedback, but Judy Ann will be monitoring the chat along the whole presentation. So please feel free to put your comments and questions in there. Thanks, Lisa. Can everybody see my presentation?
Yes.
Or
at least I can.
Okay, that's great. It's interesting to be looking at this and wondering what people are looking at. Well, okay, now that I'm in Zoom, there we go. So I just want to quickly say that the Hanley Center, where Judy Ann and I work, is a legacy nonprofit organization that serves a mission of trying to create positive change in the healthcare system by offering longitudinal leadership development courses around the values that you see here. It really is about creating positive change. So that's why we're here today, to build awareness around implicit bias and to explore the role implicit bias may have on the disparate impact that COVID-19 has in Maine. We're going to spend the day first by just defining what we're looking at in terms of implicit bias, but also we're going to explore the role it has in patient-provider relationships and how that then will roll over into the bias as it relates to care for COVID-19. Since implicit bias is really focused internally in how we show up in our work, we're going to talk a little bit about owning our own explicit biases, how you can go ahead and take a test, figure out how it is, what you're carrying, and what strategies we'll be using to mitigate that bias. And because we're about change and not about training, I'm going to have you set an intention right now at the beginning to think about one thing that you can commit to today to do some change in the way you show up at work so that we can change how implicit bias works. So as you go through the day, just know at the end, I'm going to be asking you to commit to one strategy to incorporate. I'd love to know who's in the room. So this is the one place, as Lisa said, that we're going to ask you to go into chat, and Judy Ann is going to help monitoring. Who do you work with? What types of populations show up in your day-to-day work? I've listed some here just as a way to prompt some thoughts, but as on the people, for the people on this call, what populations show up every day? We are one of the whitest states in Maine, in New England, actually, United States, right? We go back and forth with Vermont, but we are having a growing impact for populations of this as they're growing. What's showing up?
So everybody please chat in and I'll share what I'm seeing.
I hear typing, so something must be going on.
Intellectual disabilities, mentally ill, elderly, Native American, adults with autism, intellectual disabilities, people with autism, new immigrants, homeless, elderly, refugees, mentally ill. Let's see what else is coming in. Individuals with co-occurring mental diagnosis. Lots of people working with individuals with intellectual disabilities on this call. Many staff are from other countries and cultures, I hear. Immigrants, asylum seekers, elderly, LGBTQ, people with chronic illness, substance use, low income, transgender, substance use again, brain injury patients. It's quite an array, Janet.
Okay, great.
A variety of sexual orientation or identifying. You tell me when you're ready. There's still a few coming in.
That's good. People can continue to watch chat as we go along. I just wanted to bring that to the forefront for everyone. We are going to be showing 2 vignettes that we put together with DHH and CDC to look at 2. I mean, we only have an hour, so we can't look at all the folks who we're working with, but it's good to just know that they're obviously you're on the call, so we work with a lot of populations. So to begin our kind of journey into self-awareness, let's start with the definition. The definition, let's start with bias. We all know what bias is, right? It's an inclination, a strong inclination of mind or preconceived opinion. When we talk about implicit, we're talking about below consciousness. So when you put those 2 together, implicit bias refers to the attitudes or stereotype that affect our understanding, our actions, and our decisions in an unconscious manner. Definitions are all fine and good, but let's unpack it. What does that really mean? So in the next 2 slides, we're going to talk about what it is and what it isn't. First of all, implicit bias is activated quickly. It's unconscious. I like unconscious, but I like really below consciousness. It's biologically rooted. It's automatic. It's activated unknowingly by situational cues, and it's learned over time. If you look at those concepts on the left here, we're really talking about a biologically based learned response. And if we all think about it, the brain is a major predictive machine. It takes in senses from the world, and since it can't address the millions of data points that are coming in, it creates a very strong filtering mechanism. So it filters, it looks for commonalities, and it generalizes into categories and or stereotypes, and then it joins with the memories that we have to create the stories or the biases that we have around what's showing up. Because the brain is constantly searching for safety, as you all know, working in the fields that you are, it really, the reptilian brain or the amygdala, I always mispronounce that and I practice, the amygdala is constantly searching for safety. And when we're dealing with implicit bias or working with people that are not in our group or different, it's triggered. Is it safe or is it not safe? And in doing that, it really narrows our attention span because we're just trying to stay safe. When we look at the cues here, you'll see that because it's below consciousness, you could be walking around. I know when I was a kid, I used to walk around. My dad was a physician, so I walked around with him on rounds sometimes, and just the smell of the hospital would bring back memories now as I'm older. Or you may have a cue, the color of somebody's skin, the tone of somebody's voice. It triggers like a habit, and it automatically brings back some of those emotional memories that we bring into the stories that end up affecting our behavior and attitudes, as we saw in the slide before. Let's go to what it's not. As we said, it's activated. It is not activated intentionally. It's automatic. You can't access it through introspection. It's below our thinking mind. And it's not always consistent with our declared beliefs. You have values. You may have strong values of fair treatment, but it may show up differently with these implicit biases. And it has nothing to do with what your values are and your intentional behavior. And because it's operating below consciousness, that's where it may be inconsistent with our stated values. To go on a little bit more, it really is a habit of mind because it's learned over time. Because it's learned over time, as we saw on the last slide, you get into a habit of thinking. The brain wants superhighways and it creates patterns from our history. So, since we can't affect it by introspection, we really have to look at habits, and we'll spend that a little bit so we can look for cues to come up with a different response. And it's silently influencing all the time. The key thing I want to talk about and why it's coming up today is it's triggered by stress and anxiety. So that really is important as we deal with our environment today. With COVID-19, we're all under stress. There's a sense of urgency. And when you're doing that, that just is the perfect menu for implicit bias to have stronger influences, because you don't take the time to really sit, reflect, and you're just really going on automatic pilot. Because it's below the consciousness, it's very resistant to change because you're not aware of it. But that doesn't mean it's not malleable. And hopefully today we'll be able to have some strategies to change it. The other thing is it's not always consistent with our in-group. You know, when we talk about later how to go about and explore your own implicit bias. For instance, I took one, and my implicit bias, believe it or not, is against women. I tend to think men are more successful. That certainly is not belonging to my stated belief or what I believe and operate every day, but it's there from the social learning that I've had during my life. The one thing I want to hopefully emphasize this morning is you shouldn't feel guilty about it. We've talked about it. It's a natural perceptual functioning of the brain. Everybody has it. And the way we're going to do is just to have strategies to mitigate it. It's not that there's something wrong. When you think about implicit bias and the stereotypes that you've learned and heard during the years, or as you've been talking about or witnessing healthcare or services during these many months for COVID, what behaviors do you think come up or that you've seen that are activated by a negative implicit bias, particularly for the populations that we just talked about earlier? this would be a time for you to chat in some of the behaviors that you think may show up in provider behavior because of the implicit bias silently influencing our behavior. Go ahead and type in, and I'll have Judy Ann read some of what you're doing, typing in.
All right, if you all could type in the chat, great, thank you. And then I'll share what I'm seeing, Janet.
Thank you.
I see pronoun errors. We certainly hear about that a lot from LGBTQ communities, talking to staff rather than the client or the patient. Being short-tempered, being fearful, not taking the concerns and issues seriously of the patient. Someone else also mentioned pronouns specifically with transgendered. Yes, definitely. Any others? Dismissiveness of patients' report of pain. I've heard others talk about just discomfort, and that shows up as being sort of quick and not listening, because there's lack of understanding of the culture of the individual.
Great, thank you.
I don't see any more coming in. Oh, one other just came in, sorry. Prioritizing issues that you find most important over what the consumer finds most important.
Great,
Thanks, Ashley.
Thank you. Those are great. I just wanted to prime the pump a little bit and have you think about it, because what we found in the research, and it came up in some of these. I'm not going to read the whole list, but you know, if you're really uncomfortable and it's silently influencing, the things that we've seen is greeting less warmly, paying less attention. You talked about taking your opinion versus what the client says. So hear about acting dominantly or speaking condescendingly or making assumptions. All of these behaviors are not what we would consciously choose to do. And you see at the top, it's microbehaviors. It's just subtle changes, subtle differences that show up that when experienced by our clients or patients or the people that we're working with, really has the effect of really breaking trust in relationships. I'm asking you to really think about behaviors, and I prompted this thought with this list, because what I'd like to do next is to share two vignettes, one of Native Americans and one of new immigrants. I wish I could show all the videos that the Hanley Center has. We developed them with the Department of Human Services and CDC. But because of only an hour, we've picked two. And what I'd like you to do as you read through these, listen to these vignettes, is really calm yourself down, put our judgment behind, and just try to experience what they're experiencing. Listen deeply. Try to look for the behaviors that we've talked about. Try to look for the experience that these folks are describing, and try to think, what implicit biases are operating in the healthcare system that are showing up as these disparate impacts. Clearly, I'm a white female talking to you about implicit bias. I can't even begin to talk about the experience disadvantaged populations have in receiving healthcare in the United States and in Maine. So I'm really happy that we've had these videos for you to bring these voices in the room. What I'd like you to do is, again, take a minute as I pass the host over to Jeannie. Jeannie is my technical guru who will go ahead and bring up the vignette. So I'm going to stop sharing now. And hopefully, Jeannie, you can bring the first vignette up. In the beginning, it's not supposed to have sound, so.
We're dying younger than other populations in the state and in the nation. And the health of some of our older people is poorer than those in the surrounding communities in the state of Maine. And that's something you can see without data.
Right now, we have healthcare, and our healthcare is good. We have great primary care, but we still have chronic disease rates at 2 or 3 times that of the rest of the state and the country. It's shocking.
As a Passamaquoddy person, a young Passamaquoddy woman, I have seen so many people get sick and die unexpectedly in my lifetime. On April 14th of 2015 of this year, my aunt, my godmother, was 50 years old when she died of a heart attack in her sleep. The amount of suffering that we have experienced as Native people because of health disparities.
In my own family, my father passed away about 7 years ago at the age of 54. His sister, who was much younger, in her 40s, passed away only a couple of weeks later. His brother, who was in his 40s, passed away about 7 years before him. It's probably less than half of my father's generation is left now.
Heart disease and diabetes actually come from a lot of smoking, as well as no activity, staying home, eating unhealthy, eating really foods of poverty. And I think if you look at sort of the overall context, we as a people we're sort of living the lives of depression.
I do believe that there is a traumatic element to all of our health, and that all of those things like poverty, and hunger and unemployment all are affecting the health of our people.
What we saw in the health needs assessment were those people that rated higher on the scores of perceived discrimination and historic loss had higher rates of anxiety and depression. So here we have this group of people that are scoring really high in depression and anxiety, and we're expecting them to be able to take care of themselves, and they can't.
Back in the day, it was alcohol, and it still is for some people. But now opiates are the choice. And so it's treating a symptom of historical trauma.
Why don't you go out there with your little grandchild and they dance a snake dance with them?
It's definitely important to take people's cultures into consideration when you're taking care of them. Our pride in our culture, our pride in who we are, when people don't have respect for that, that has an impact.
Sometimes it's just listening. And when you do that, you're on the same level. And I think that's where the key to cultural competency is basically we're at the same level, we're working on this together, and I'm interested who you are.
And this whole Western issue of coming in and treating one diagnosis in 20 minutes, you're in, you're out, that doesn't work for us.
It does make you think. It makes me, I'm 35 now. It makes me think, like, how much longer do I really have? It's scary.
Okay, I'm just going to pause and let that sit in as Jeannie moves to the next video. Might want to take this time to just write down some of what came up for you as you watched that first video, and we let Jeannie set up the next video.
Janet, someone chatted in something I think so profound, which is it's important to take into account what someone wants for their life instead of what we think they should want for their life, and how important it is to be listening, similar to what that woman was just talking about in that video. Someone else wrote in that they also, it's exactly what they told their doctor, that the 10-minute visits with just a hello really doesn't work for some individuals or cultures when that's not what they were there for. That's not what they need. And sometimes listening, true listening, is could make all the difference in the world.
And when we talk about the strategies, listening is a piece of it, and being able to set our mindful approach to doing that. And sometimes it's so difficult the way American healthcare is set up with needing to have such short visits. It's hard to be a practitioner balancing that time and the real need for complex situations in life.
Right. So thanks to Tarlin and Francine for chatting in. Bridget says you have to listen to the person before you can treat them. And you have to understand that mental health is so deeply connected to physical health, which thank the Lord that's sort of happening. People do understand that, but not everybody does.
Right. Thank you so much, everyone. That's great. I think Jeannie is ready.
I don't think my voice was being heard. Being who I am, wearing the clothes that I wear, the way I speak, there's assumption that comes with it. And that assumption is maybe I don't know what I'm talking about. We have over 6,000 Somalis living here. So refugees were displaced, not by choice, but they were displaced from their home country due to a war, natural disaster, whatever it is. Our medical providers are people who have never experienced the experiences that we have, the trauma,
the war and not understanding that maybe I was raped, maybe I had seen all my family in front of me killed. There's just so much trauma that I'm holding, and all of that is somehow coming to me now that I have a sense of safety. Maybe she had some gunshot wounds, or maybe she broke her back, fleeing from the war. I come in for an appointment. They think maybe this is what's happening with me. They then diagnose me, they give me some medication. A month later, I'm not better. I'm coming back. So it's a cycle of back and forth, back and forth. And so I don't feel many of the providers can connect with us, talk to me as a human being and say, okay, what was your history? How did you end up here? What are your experiences? Have that trust, have that connection, have that relationship. A 5-minute appointment, I'm so sorry, will not treat me as much as I need. Somali women. The Somali woman has to be subservient. She has to be shy. She has to not laugh loud. She has to not look at you eye to eye. She has to be polite. She can't yell. She has to be modest. The body language, all of that. Anything that you want. So from the culture that I come from, a white person represents authority. They come from a higher class, fear, intimidation. Maybe they know it best. You're in their country. So there's so much loneliness. There's so much helplessness. And then you've got, a child who's in crisis. We've got experiences. We've got quite experiences in this community where, a tumor wasn't caught early enough. Parents didn't understand what they needed to do. Children, who've lost their lives because there was just that coordination and working as a team did not happen. And so it's just, and we shouldn't have that. Not in this day and age, not in where we are, not in our state. And so I want doctors to know that it's not a typical patient. It's a patient that has so much trauma and so much issues, and needs a lot of education and a lot of support to be able to get the best results that they can. Coming into a doctor's appointment, you diagnosing me and talking to me and not really looking at, the deeper side to my story, may do a lot more harm and damage than actually treating me.
Thank you, Jeannie. So as we move forward, I'm just take a minute. 2 very powerful videos. I love the chat that people are typing in. I can see them a little bit now. For Amanda, who did her research. What I'd like you to do, what came up, but also as you consider the disparate impact that we've seen for COVID-19, how do you think implicit bias is contributing to the disparate impacts. As you think about the ideas and the topics that were brought up in these videos, you can type that into chat, and hopefully we can take the next 10 minutes or so to chat a little bit about that and explore it from the wealth of experience here on the call. Go ahead and chat. As I look at the research that Amanda talked about with the multi-generational households, that certainly is a concern and an idea that we have to be considering as we deal with COVID. Yep, non-access to tests because of lack of health care.
Above those, Janet, I was seeing really a theme come out around just lack of understanding about these populations. If we could just, and you'll talk about this as you're getting to the strategies now, is we could just get to know one another, get to know these populations, and be able to ask just some basic questions and develop relationships. It's so important to understanding and delivering appropriate care.
It's interesting that you say that. I didn't bring it up in my slides, but in my reading and as I'm looking into this, just the implicit bias on how we deliver health care, that it's so quick and that you treat just one diagnosis. Sometimes when they said a 5-minute appointment doesn't serve, just how do we shift? How do we show up differently, right? To really know the whole person, be able to see rather than the 5-minute diagnostics, which I'm not a provider, so I can't comment other than to say there's a real balance between the needs of these populations and some of the systems that we have to work in. Lack of patience, right? That came up in some of the behaviors. Because it takes time to listen and to get to know, right? And sometimes when conversations are difficult, we can get frustrated and lose patience. The pervasive tiredness. Anything else come up just in general as you watch the 2 videos? When you think about yourself interacting and providing services every day. Any insights or any reminders?
Inza writes, when you don't listen, you don't understand. So the lack of understanding may be coming from failure to listen and failure to consider each person's particular situation.
Right.
Thanks, Inza. Yeah, this is great.
I like to stop talking to staff rather than the client patient, right? Because when it's difficult, sometimes we take a shortcut and talk to staff. Really not being present. What else? Francine says in terms of the huge judgment around the Somali population in Lewiston, right? And the lack of education, right to the stereotypes, right to the social conditioning and cultural conditioning we've had over time, particularly when there's a big shift in population, how to get to know one another. I hear typing. I can't wait to see what's going to come through.
It's me, I'm sorry.
Oh, okay.
Janet, Tarlin
Yes.
brings the issue of time, and if implicit bias is best mitigated by taking a pause and examining what those biases may be and trying to intervene in them. What of a system that does not typically allow for much time? I'm sure many providers on this call are thinking, how can I come up with more time to ask all those questions and gain that understanding? What insight or advice might you give?
It's interesting, when I was listening to a mindfulness speaker the other day, she said, you know, to get yourself prepared to really listen. We're going to go through this with strategies, but taking 10 seconds for you before you even have interaction. 10 seconds isn't that long. Here's 10 seconds. In doing that, you can reset so that you can be present, right? So maybe by being more present and you're off the urgent treadmill that you're on, that maybe you show up differently, and can you hear more deeply in the time that you're allotted. I know that there's time to do that. You have so much time you have with patients. How you show up also helps to listen. And are there ways that you can start with asking a few more questions up front before you get in there? I can't extend patient appointment times, but I can help you show up differently and maybe ask different questions when you meet people. It's a tough conversation. I get the realities. Does anybody else have any wisdom that they can share on that question? When I'm saying take time, be holistic, learn, and then you have to meet the timelines.
Bridget raises a really big comment, a really important point there, that providers may see a patient as non-compliant when in reality there's larger, social determinant of health issues going on with the person, just doesn't have the resources and the support they need to be compliant.
Right, and so how do you ask questions? What barriers are the patients facing to even show up and to follow through on those? And when we talk about strategies, we are going to ask you to ask those questions, right? Rather than making the assumption of non-compliant. Great point. We'll be talking more about that. Oh, interpreting. Things are slower with interpreting, right? Taking time to ask the right questions. Hopefully after today, we'll be thinking about what are the right questions. Sometimes we are in habits, as I talked about earlier, and we do what we've always done. And maybe if we take a pause and think of different questions, that will help us get more understanding. Great comments.
One thing I would add from our previous webinars is that we know that in Maine, in our medical professions, there's not a ton of diversity within our provider community. And so what we don't have is the ability to lean on staff for folks to be able to come in and see someone who looks like them and see someone who knows their culture and immediately feel a connection and ability to share a little bit more about what they're experiencing. But we do know that there are many organizations in Maine now training community health workers to help be that bridge. And so where our providers may not have time, realizing that utilizing community health workers and in the long term investing in the diversity of our staffs can have a really big impact on the ability of communities to build trust with providers and for us to be able to get the information that we need more quickly, but also more effectively in order to actually provide more holistic treatment.
Liana, you're taking away my next half of the presentation. That's true, right? We have to really have diversity in our staffing so that people not only feel comfortable when they come in and see themselves as belonging in the practice, but really have a way to have somebody in the practice who can speak directly to them. Staff diversity is a very important solution to moving this forward. Thank you. Why don't I do this? Why don't I move to some of the strategies, because I think it's going to bring up some of the conversation and prompt maybe some more comments. So I'm going to share my screen again. And hopefully catch up to us. So strategies, let me use these as a talking platform, and hopefully it will bring in the comments that we've had before, but also generate some new ones. I like to bucket my response, my strategies, so that when you're in the thick of things, you can ask these questions. What do I have to do for myself in this moment? What do I have to attend to in this relationship? And then more long-term, what structures and strategies are either supporting or adding barriers? And then organizational strategies to talk about, for instance, what Liana said in terms of more diverse staffing. So that's how I've chosen to bucket our solutions. So in terms of managing yourself, it really is about self-awareness. And folks who are on this call, you're probably speaking to the choir. But to know that you have implicit bias and to be able to leave your comfort zone to explore it. At the bottom of the page, you'll see a URL that goes to Posit Implicit, which is the Harvard research, where you can go in and take a test, and they can test for race, they can test for age, they can test for religion, all different kinds of biases, so that you can explore what shows up for you. That's where I went and said, I think men are more capable than women implicitly, when I would say that's not my value and that's not how I show up. Why is it important to take these tests? It's important because research has shown that open acknowledgement of your biases really does facilitate your sensitivity. Because if you deny, or if you try to suppress it and say, I'll just show up, I'll just be nice, the cognitive energy that it takes to suppress what's going on and then to act, making difficult decisions and dealing with complex situations, you're so diminished, because so much of your cognitive capacity is just being used to really suppress those biases. So to just say, I know it. I know that. But for me, I have drunk the Kool-Aid with regard to this cultural messages I've had, for instance, in terms of men aren't. And then, so when I do it, I then look for triggers, right? So it's really important to be able to be humble and to acknowledge and to be curious. Once you know them, how do you expand? How do you make sure that they're having less silent influencing? What you want to do is you want to replace those years of stories in the media, other stereotype information that you have in your memory banks, and replace it by reaching out to people and sharing your biases. Talk to people who are in groups that you may have found out that you have an implicit bias to. Learn people as individuals so you can replace positive stories from those folks with the stereotypic stories that you've learned over your life. The other thing is called counter stereotyping. Think of people who you really admire in those groups. So when you're interacting with folks from that particular group, that you can have easy access to positive examples of that. Part of our memory and how it interacts with our implicit bias is it goes for what's available. So if you replace all those available media and cultural stories with new positive stories, those will be what's available to you when you go on and deal with people. So really monitor the information. We're totally bombarded with all kinds of media these days, whether it's Facebook, smartphones, TV. Just start being aware of, geez, what's going on, what's showing up in my world, and realizing that's being banked in your subconscious and will be what's available to you when you're interacting in life. So replace it. We talked about stress and urgency when we talk about the 5-minute interaction or the whatever the time limit is. And we have to manage that, right? We talked about mindfulness, taking that 10-second pause so that we can stop the brain when we're running around feeling really urgent to make sure we get all the work we need done, get out of that check the box task. I'm going to ask the same questions I've always asked, to really sit down and open up our brain to be able to see a wider picture. When we really do mindfulness before, we find out that we can really attend to more information. Emotional regulation I have up there really to talk about research that says trying to keep positive affect and joy in our work, which I know is difficult when we're working really hard and dealing with these difficult issues. But the more we try to have positive attitudes, what we find is that we increase our positive emotions during the encounter. It leads to more inclusive behavior, so that naturally the way we show up will be more inclusive. Those questions may come to mind more easily. It facilitates empathy, and it increases our ability to see people as individuals rather than categories or stereotypes. So by managing yourself through mindfulness, even though you have short time, you'll be much more aware and empathetic and ability to see the person in front of you. Old habits die hard, right? There's a wonderful book called The Power of Habits by Charles DeYoung, which really talks about cues and how we change habits. We talked about how it's situational cues will trigger implicit bias. Well, we need to be aware, what are our cues? As you go through the day and you come up on different situations, what's coming up for you? Understand to identify those cues. So for instance, if I see a homeless person, then I'm going to take a deep breath and focus person as an individual. You can do that in your day, right? Otherwise, you're going to be unconsciously going through your day with these silence influencers. The key thing is to just notice the cues, because then it goes from the subconscious or below conscious to the conscious mind, and you can choose to respond rather than just to react in your old habits. So as before I go on to managing relationships, in terms of managing self, is there anything that comes up for you in what we talked about? You've brought up most of it. There was so much wisdom in the room. I expected that you would. Great. I just noticed time, so I'm going to go quickly through. The other thing is managing relationships. You manage yourself. Now, what's happening in the space between you? You want to make sure, as we said before, make sure that you look at the person as an individual. Make sure you take perspective taking. We talked about how important it is to realize that people are not being non-compliant. They're having barriers. You know, how long did it take them to get to your office? Is there an opportunity for them to come for follow-up appointments, or did their job or situation not allow it? The historical trauma that people talked about, that understanding and acknowledging all of that creates safety and common ground. The other thing I want to say is, remember, it's a relationship. They're coming too with biases, right? We talked about, we heard in the video, our Somali woman saying that, you know, white people, white doctors or white care providers, or people that we consider them people in authority, a higher class. They generate fear and intimidation. So if you want to have good conversations with them, you have to realize you have to use your skills to bridge that bias. And finally, Managing system and structures, really look around. What services do you provide? Are your assumptions about what a patient is tied to what an American-born, American skilled and health system educated person uses, or are your systems really acknowledging the real different experience and the health literacy of your patients? Also, it's really important to partner with representatives from the different populations. We found, as we've done discussion groups, that the one thing they want to do is say, invite us in, help us look at your structures and systems and forms so that we can help you see how to make it more effective for our population. Process, again, we talked about assumptions, patient circumstances in terms of the barriers, the cultural representative that I talked about, so important, whether it's somebody who's greeting people in the front office or whether it's somebody who's an ally who can come in and help you look at your office and your structures. And then organizational, just make sure that you have the training, that people know how to give equity specific feedback. And again, it's how can you impact the stress and joy in your work? And I know I'm moving up on time. And so what I'd like to do is really have you, again, take a minute as I'm passing this back to Lisa to make a commitment and write it down right now. What one thing can I do? And I often coach people as sometimes awareness is a really good thing, to just sit and for the next week, really start paying attention to cues so that you can change your behavior. Thank you very much. I really enjoyed spending time with you this morning. Lisa, I'm going to pass it back to you.
Great. Well, thank you so much, Janet and Judy Ann and Jeannie, for helping out, and for everybody for being so actively involved and sharing your thoughts. I think it was really thought-provoking, and I think gave us all some work to do in terms of thinking about our own approaches and internal biases. So thank you all. As mentioned at the beginning of this webinar, we are recording these and posting them to the Maine CDC website. You kind of have to just go to the main page for COVID and scroll down, and you'll see the link. We also are planning our next webinar, the last in our monthly series. We will likely go to quarterly after that, for, again, the third Wednesday of the month in November, November 18th, where we're going to be continuing on this theme of addressing health disparities, and specifically in COVID, and talking about vaccine hesitancy and preparing for what we all anticipate as a COVID vaccine or vaccines sometime soon. So we're welcoming some of our own experts here in Maine, as well as an expert in vaccine hesitancy. We do remind you all that you need to register. You can use the same link, but register for the November session. And appreciate everybody's interest and efforts, and we look forward to seeing you then. Thanks again, our Hanley colleagues, and everyone for joining.